Hello my dear students, in this lecture we will learn about the ACL rehabilitation. So, the learning objectives of these lectures are at the end of the lecture, students should be able to explain the pathomechanics of ACL injury, rationale behind the ACL rehabilitation, goals and long-term intervention of the rehabilitation. So, what is the pathomechanics of ACL injury or mechanism of injury? So there are three common mechanisms of ACL injury. The first, in which the ACL involves a non-contact valgus and external rotation stress to the knee as the foot is planted on the ground, which means that when the foot is on the ground or planted on the ground, there will be valgus and combinedly external rotation of this knee, which may cause the ACL injury or ACL tear. The second mechanism will be the knee hyperextension combined with internal rotation can also produce tear of the ACL. The third mechanism that we call phantom foot mechanism. This mechanism occurs when a skier falls backward with the knee flexed and the tibia internally rotated. So that may result into ACL tear or injury to the ACL. So the next heading is impairment, activity limitation and participation restriction which may patient complains of. So following trauma, the joint usually does not swell for hours. If the blood vessels are torn, the swelling may be immediate. If the tested when the joint is not swollen, the patient feels pain when the injured ligament is stressed, or if you perform any special test, that is varus or valgus test or anterior drawer test, latchman test. If there is a complete tear, instability is detected when the torn ligament is tested with the help of special test. When effuse motion is restricted, the joint assumes a position of minimum stress, usually flexed at 25 degrees of knee flexion, and the quadricep muscles are inhibited. When acute case, the knee cannot bear weight and the person cannot or patient cannot ambulate without an assistive device. With a complete tear, patient may present with instability and the knee may give way during weight bearing. That means buckling of the knee is present, which would prevent the individual from returning to specific work or sport and recreation activities that require dynamic knee stability. Which means in complete tear there will be total instability and there will be difficulty for patient or person to return to his sport specific work or sport specific recreational activities. Then, so what are the ACL rehabilitation rationale? So the first rationale will be the reduction of inflammation as patient presents with pain, swelling and signs of inflammation after ACL injury. Then to regain the full range of motion after ACL injury, avoid arthrofibrosis. What do you mean by arthrofibrosis? So arthrofibrosis, it is a complication of injury where an excessive scar tissue response leads to painful restriction of joint motion, with scar tissue forming within the joint and surrounding soft tissue spaces, which may restrict the range of motion of the knee joint. So to avoid arthrofibrosis, physio rehabilitation is necessary for ACL patient. Next rationale is to enhance early weight bearing, early initiation of hamstring and quadricep activity, ability to return pre-injury activities, neuromuscular and proprioception retraining, and functional retraining to return to sport-specific activities or recreational activities. So the next heading is how the orthopedician surgeon decides whether to go for conservative or surgical treatment for ACL tear. So it will depends on different factors. So first factor is activity. Sedentary individual can usually function with some loss of knee stability and can accept to return to pre-injury activities following a course of non-operative management. Means what? A sedentary individual can opt for conservative management if the tear is grade 1 and grade 2. Then a sport specific person cannot go for conservative treatment, as it may persist the instability of the knee joint, which may destroy the sport specific person's career. So sedentary individual can go for non conservative management, and the sport specific person should go for operative or orthoscopic repair of ACL. So the next heading is the degree of instability. A positive pivot shift test is indicative of significant degree of instability. In the patient with longer term ACL deficiency, symptoms such as recurrent episode of giving away, that is buckling, indicate instability. For those patients, ACL reconstruction is highly recommended. So as the grade 1 and grade 2 ACL tear required only conservative type of physiotherapy management, and then grade 3 and grade 4 required the orthoscopic repair or open repair of ACL tear. So the next factor is associated abnormalities. Many surgeons would advocate ACL reconstruction in patient with concomitant meniscal injury, in what we call that is Oud-Hongyu triad, in which the medial meniscus, medial collateral ligament and ACL ligament are combinedly injured. So we called it as Oud-Hongyu triad or unholy triad. If with ACL, any other structures of the knee, that is including meniscal or medial collateral ligament, got injured, then surgeon decides that he or she should go for orthoscopic repair of ACL, that is operative management of ACL tear. So social factors can affect the choice of conservative or surgical treatment, because some patient cannot afford the repair charges, that is orthoscopic repair charges, so they have to go for conservative treatment of ACL. So the ACL rehabilitation is divided into 3 ways, that is pre-rehabilitation, pre-physiotherapy rehabilitation, post-physiotherapy rehabilitation, and third is conservative physiotherapy management of ACL. So as evidence suggests, and according to some authors, a study conducted on the effectiveness of pre-operative exercise physiotherapy rehabilitation on the outcomes of treatment following ACL injury concluded that the pre-operative physiotherapy rehabilitation is effective for improving the knee related function, improving muscle strength and quality of life. So pre-rehabilitation is always necessary for patients with ACL injury. Second one is post rehabilitation, that is after orthoscopic repair or repair of ACL tear. The third one is conservative. So we'll see one by one. So first will be the pre rehabilitation. So first goal, to decrease swelling and inflammation. For this we can apply cryotherapy for 20 to 30 minutes, IFT or TENS to the affected part where the swelling is present around the knee joint. Then elevation and ankle pumps can be advised 10 repetitions per minute for 20 to 30 minutes with compression bandage. So that will drain the excessive accumulation of fluid and helps to relieve the swelling and inflammation. So rationale behind to manage the swelling and inflammation with the help of IFT, TENS and cryotherapy, that is it will control the pain and swelling and also control the edema. Then the second goal will be to decrease pain. So for that also we can apply the ultrasound, IFT or TENS. Then the third goal will be to increase the quadriceps strength. For that, in pre-rehabilitation, we will do minimal intensity isometric exercises of quadricep and hamstring, that is quadricep setting exercises and hamstring setting exercises, to improve the neuromuscular coordination and function. Next goal is to maintain the hip strength. For this, the pain-free range of motion of knee, active range of motion of hip, abduction, adduction and extension can be performed. So it will emphasize self-management of range of motion program and will prepare the patient for easy transfer. So the next part is post rehabilitation. So ACL orthoscopic reconstruction can be performed or can be chosen as a operative method of ACL injury. So it is performed through a small incision to help visualize and make the tunnels for placement of the ACL graft. The aim of an ACL reconstruction is to replace the torn ACL with graft that reproduces the same kinetic function of the ligament. The most commonly used grafts are. So what are the indications for ACL surgery or orthoscopic repair? So if disabling instability of the knee due to ACL deficiency caused by complete or partial acute tear or chronic laxity. If disabling instability is there, so we should go for the operative management of the ACL tear. So next indication will be the frequent episodes of the giving away, that is buckling, during routine activities of daily living as a result of significantly impaired dynamic knee stability despite a course of non-operative management. So if patient goes for non-operative management, there will be a lifelong instability. Little instability may be present. If it frequently occurs, then the person should go for operative management of the ACL tear. Then if ACL injury associated with medial collateral ligament at the time of ACL injury, to prevent the lax healing of the MCL, so surgery should be performed. High risk of re-injury because of participation in high demand, high joint load activities related to work, sports and recreational activities. As we discussed in earlier, that is how we will choose about the conservative and surgical treatment. So as we discussed, if sport specific person is there who involves the high demand activities, so he or she should go for operative management of the ACL tear. So there are two types of the graft that can be used during the orthoscopic reconstruction surgery of the ACL. So first one is bone patellar tendon bone autograft. So there are some advantage of bone patellar tendon bone autograft. So first one is it has a high tensile strength stiffness similar or greater than ACL, that is 2977 Newton. So second advantage is it has rapid vascularization or biological fixation, so that it heals within the 6 weeks and patient can resume his activity early, and ability to return pre-injury level high demand activities safely. So there are some disadvantages of bone patellar tendon bone autograft. That is, it may persist the anterior knee pain of the patient. Patient may complain pain during kneeling after bone patellar tendon bone autograft, or extensor mechanism and patellofemoral dysfunction may be present. Long-term quadriceps muscle weakness may be present. Patellar fracture during the graft harvest, which may be the complication of bone patellar tendon bone autograft. So these are the advantages of bone patellar tendon bone autograft. So the next graft fixation is hamstring, that is tendon to bone fixation. So it has advantages that it has high tensile strength, stiffness greater than ACL, that is 4000 Newton, which is much greater than bone patellar tendon bone autograft. So it is the strongest fixation with least amount of slippage. So it has a least amount of slippage chances as compared to patellar tendon bone autograft. So nowadays hamstring and gracilis autograft are commonly used. A randomized controlled trial was conducted on comparison of patellar versus hamstring tendon graft in orthoscopic repair of ACL, concluded that better outcome of hamstring tendon reconstruction for the two parameters of pain severity and rehabilitation. So hamstring tendon group had least knee pain than patellar graft tendon bone graft group. So the rehabilitation brace has open cell foam interface that encases the calf and thigh, means a open cell foam that covers the calf and thigh, which is shown by capital letter A in figure. Then it consists of adjustable velcro straps for closure, which is shown by capital letter B. Then it has side bars, which is shown by capital letter C. And it also has single axis or polycentric hinge, which is denoted by capital letter D in the figure. So we'll now discuss the biomechanics of the rehabilitation brace. As we discuss the structure of the rehabilitation brace, we'll continue with the biomechanics of the rehabilitation brace. The force system of this orthosis apply a pair of anteriorly directed forces at proximal posterior thigh, which is denoted by numerical 1 or number 1, and distal posterior calf, which is denoted by number 3, against a posteriorly directed force, which is denoted by number 2, applied over on either side of the patella according to the Jordan's principle of the orthosis. So the two forces are acting against the counteracting forces, which is applied over or on the either side of the patella and denoted by number 2. Brace is unlocked for exercise as soon as range of motion is permitted. If is worn throughout the day and sometime is worn during the sleep for protection for first week of post-operative phase. The brace is lock in full extension during ambulation. So weaning criteria for brace is when the full active extension is achieved, then you can wean the brace, or if 90 degree or 110 degrees of flexion is achieved within the period of 4 to 6 weeks of post-operative phase. So you can wean the brace. So the next brace is functional brace. It provides additional protection as rehabilitation phase is completed or rehabilitation is completed and patient returns to normal activities. It will be used to reduce the risk of re-injury during the advanced phases of rehabilitation also, and when participating in high demand sports or heavy manual labor. So we'll see structure of functional knee orthosis or functional knee brace. It has a medial and lateral upright. It also has single axis knee joint with a medial fulcrum pad. It has a broad elastic thigh and calf cuff strap to hold the orthosis in position, and a set of derotation strap to control the movement of the tibia on femur to provide mediolateral and rotational stability, or to control the mediolateral and rotational instability. So we'll now see the biomechanics of functional knee orthosis. The stabilizing forces that are typically applied by the orthosis include a posterior force over the anterior proximal thigh, which is denoted by number 1 in the figure, an anterior force at the distal posterior femur, which is denoted by number 2, and a posterior force at the proximal anterior tibia, which is denoted by number 3, and an anterior force at the midshaft of the posterior tibia, which is denoted by number 4. So in this way the orthosis stabilizes the knee joint and to provide the rotational stability. So from phase 1, the goal second is to decrease swelling, inflammation and pain after post-operative intervention. So the intervention to decrease swelling, inflammation and pain, the cryotherapy can be given for 15 to 20 minutes 5 times a day, and therapeutic laser can be given to decrease the inflammation and improve the oxygenation of the healing tissues. Cryotherapy induced decrease in nerve velocity. Decrease in nerve conduction velocity may decreases the nociceptor activity. In this way the pain can decreases by cryotherapy. A therapeutic laser can decrease pain by increasing microcirculation and increasing oxygenation to tissue with reduction of knee swelling and intensity of inflammation. Larger Laser reduces the inflammatory process by altering prostaglandin synthesis, decreasing interleukin 1, enhancing lymphocyte response, and decreasing C reactive protein and neoprotein levels. So, this way, therapeutic laser can be given to resolve the inflammation following post-operative intervention. Goal third for phase 1 is to allow protective weight bearing. So, as tolerated with 2 crutches as early as possible with long knee brace, the protective weight bearing can be started. Progress during the next 2 to 3 weeks based on the patient's symptoms. So, start from the partial weight bearing to full weight bearing. So then full weight bearing and ambulation without crutches is permitted by week 4 after post-operative period. Taylor and colleagues show that immediate weight bearing reduced muscle inhibition at knee joint in the early post-operative period, as demonstrated by an increased return to electromyographic activity in vastus medialis obliquus, and also reduction in the development of anterior knee pain in patients who began immediate weight bearing. So the goal fourth of phase 1 is to enhance voluntary isometric and dynamic activation of knee musculature, for which electrical stimulation can be given, which improves the quadriceps strength. So the contraction time 10 seconds followed by 50 second rest for 10 to 15 contraction. Evidence suggests that electrical stimulation and exercise was more efficient than only single electrical stimulation to the muscle, which means exercise should be given concomitantly with or simultaneously with electrical stimulation, so which will be more beneficial for a patient to recruit the muscle activity. So to improve knee flexion, sitting assisted flexion hangs can be given in sitting or chair sitting. Supine heel prop can be given. A bolster can be placed below the ankle joint or a calcaneum and ask the patient to just isometrically contract the quadriceps, so which may improve the knee extension range of motion or reduce the extension lag. Then the next exercise will be passive overpressure with load to increase knee extension range of motion or to improve the knee extension lag. So this exercise can be given with the heel is raised on the bolster. We can apply passive overpressure over the distal anterior thigh in the direction of extension to increase the extension. So that is what your passive overpressure with load in the direction of extension to improve the knee extension range of motion. So the goal 6th will be for phase 1 is to education of functional training and enhance neuromuscular control of the knee and lower extremity. So for this, aerobic conditioning of upper extremity can be given, that is upper extremity ergometry can be given, and well leg bicycling can be given to enhance the functional training. So the second intervention will be proprioception. For this, the activity included stable platform, eyes open and closed. So on stable platform, patient has to stand with eyes open and closed. Then second activity will be to improve proprioception is seated ball throwing and catching on stable platform. Then all these exercises for week 1st to 2. Then how to progress these exercises for week 2nd to 4th. Then mini squat can be started from 0 to 30 degrees of knee flexion. Then upper extremity ergometry can be progressed with increased resistance or speed. Then leg press can be started from 0 to 30 degrees of knee flexion and extension. Then stair walking can be started, marching to improve the hip flexor neuromuscular activation. Aqua therapy can be given if the stitches or incision has been healed or no complication is there. So pool walking and pool jogging can be initiated. So from week 2nd to 4th, as we discussed in early phase, that is week 1st and 2nd, in proprioceptive activities we included the stable platform. So we will progress to unstable platform in week 2nd to 4th. So on unstable platform the patient has to stand. Second, we will progress the on unstable platform with upper extremity movement. Then mini trampoline standing can be started, and standing ball and throwing activity can be conducted to improve the proprioception of knee joint. Then we'll start with the phase 2, which will extend from week 4th to week 10. So goals for this phase is to gain full pain-free range of motion, 4 on 5 muscular strength, then dynamic control of the knee, to improve kinesthetic awareness of the knee and to normalize the gait pattern. So for this the intervention can be given, that is multiple angle isometrics for knee flexors and knee extensors, also for knee hip extensors and hip flexors and hip abductor mainly, because the if hip abductors are weak then it will create the valgus force at the knee joint which may displace the graft. So it should be necessary that after ACL injury the hip abductors must be trained fully. Then PRE, that is progressive resistance exercises, and leg press can be progressed in this week from 0 to 60 degrees. As earlier we discussed that 0 to 30 degree can be started in initial phase and it will be progressed to 0 to 60 degree in second phase. Step up lateral and forward, double single leg squat, lunges in multiple plane. Lower extremity stretching can be continued if flexibility is not achieved. Then proprioception training can be progressed to single leg stance on balance board. Earlier we have discussed that is double leg stance. Here we progress it with single leg stance on balance board. So first figure shows step up lateral and forward, then leg press 0 to 60 degrees, then proprioceptive activities, that is single leg stance on balance board with handheld weight can be conducted. Then functional training, that is continue bicycling, that is well leg bicycling, pool running, stair steeper, country skiing machine, stair jogging, stepping drills and balance beam activity. So stair steeper activity can be incorporated to improve the knee flexors and extensor, hip flexors and extensor strength. Balance beam activity to improve the proprioception. Cross country skiing machine to improve the hip flexor, knee extensors, knee flexor and hip extensor strength. Then stepping drills can be incorporated for sport specific person. Then we'll move towards the phase 3, that is minimum protection phase, which will extend from week 11 to 24. So we can continue lower extremity stretching if flexibility is not achieved fully. Lower extremity strengthening, that is PRE, progressive resistance exercises, multiple angle isometric and dynamic resistance exercises, elliptical stepper, stair stepper, box jump activity, jumping rope, mini tramp bouncing. Earlier we have only discussed in early phase, that is mini trampoline standing. Here we have progressed to mini trampoline bouncing. Ball throwing and catching on unstable surface. Earlier it was ball throwing and catching on stable surface. So here we have progressed ball throwing and catching on unstable surface to improve the proprioception and balance. Then shuttle run can be conducted for sport specific person to improve the agility of that sports person. So advanced lower extremity strengthening can be resisted walking forward and walking lateral, resisted sitting in the chair and resisted standing up from the chair. Then hamstring curl with bridging on Swiss ball can be conducted or can be given. So advanced proprioceptive training can be given, that is unstable platform ball throwing and catching, mini trampoline bouncing and box jump, as we discussed earlier. So agility drills can be given to sport specific person to improve his agility. which may be helpful for his or her performance. So in figure we can see there are 5 cones are placed, so person have to cover the distance in minimum time and reach the start point and end point. So the phase third is conservative management. So the rehabilitation program for the conservatively managed ACL is similar to the management after reconstruction. Derotation brace may be used to provide additional stability. The principle of initial reduction of swelling, pain, restoration of full range of motion, increase muscle strength, functional rehabilitation, and finally return to sports all apply. The rate of progress may be slower or faster than after a reconstruction depending on degree of instability. The agility drills and sport specific drills may not be possible in patients with ACL deficiency, as we have not repaired that ACL tear. We are managing only conservatively, so agility drills and sport specific drills may not be possible in patients with ACL deficiency. So outcome measures can be used, that subjective will be Lashlom knee score, Tenger activity scale, Cincinnati knee rating system, and for functional outcome we can use Hop test. So these are the references of my lecture. So you can refer these books.